Good day, and thank you very much for this invitation to be part of the 19th course on the fundamentals of clinical hypertension. I'm Dr. Cecil Jimeno, and the lecture that's been given to me is on hypertension in diabetes and the metabolic syndrome. In this lecture, I only have 4 bullet points. First, we'll talk about the epidemiology of hypertension in diabetes and metabolic syndrome. Then go through the pathophysiology of hypertension in diabetes and obesity, and subsequently talk about some of the highlights from the 2020 Philippine Practice Guidelines on hypertension, focusing on hypertension among persons with diabetes. Then we'll round up the lecture with a brief discussion on the management of hypertension in obesity. So first, let's talk about the epidemiology of hypertension in diabetes. Hypertension is in fact so common among persons with type 2 diabetes that it's already an anticipated comorbid condition. In the DiabCare survey in 2008, we found hypertension in 70% of persons with established diabetes, especially type 2 diabetes in the Philippines. And these are people or persons with diabetes whose estimated duration of diabetes is 5 or more years. However, even among newly diagnosed persons with diabetes, we found in the Candy Manila survey in 2009 that 40% of newly diagnosed persons with type 2 diabetes also have hypertension. In the Philippine National Nutrition Survey in 2013, we also found that those who have adults who have diabetes have a prevalence of hypertension of around 43.4%, and this is double the prevalence of hypertension when compared to those with normal glucose tolerance, which is around only 20%. So you can see that persons with diabetes typically will have hypertension. Now let's talk about hypertension among persons with metabolic syndrome. But first, let's talk about the criteria for metabolic syndrome. We all know that over many years, metabolic syndrome has had many names and many criteria from various organizations throughout the world. But it was in 1988 during the American Diabetes Association Banting Award lecture that Dr. Gerald Driven actually first introduced first the concept of the link between insulin resistance and other metabolic abnormalities, calling it Syndrome X. Syndrome X has since been called metabolic syndrome, and over many years, the many criteria have changed, but it was in 2009 when the International Diabetes Federation harmonized the criteria. So the metabolic syndrome, its various criteria, represents actually a group of people of higher cardiovascular risk. And it is typically because of a background of increased insulin resistance as manifested by being overweight or obese, especially having central obesity, along with metabolic abnormalities like elevated triglycerides and low HDL, together with the phenotype of elevated blood pressure and elevated blood sugar. So now in the IDF 2009 criteria, metabolic syndrome is defined by any three of the following. First is an elevated waist circumference to represent visceral adiposity using population and country-specific definitions. So then, just to let you know that in the Philippines, being Asians, we follow the WHO Asia Pacific cutoff, recognizing that the risk of diabetes is increased at much lower BMI for Asians compared to our Caucasian counterparts. So in the Asia Pacific cutoff, we know that the BMI threshold that defines overweight is 23 kilograms per square meter. The cutoff for obese for BMI is 25. And the waist circumference cutoff is 90 in men and 80 in women. much lower than the original international WHO cutoffs. So this is what the IDF criteria is saying. When we use the term elevated waist circumference, we should use population and country-specific definitions. Now, coupled with this visceral adiposity is the metabolic abnormalities of triglyceride more than or equal to 150, low HDL cholesterol of less than 40 for men and less than 50 for women, elevated blood pressure of 130 over 85 or greater, and a fasting blood glucose of 100 milligrams per deciliter or greater, representing pre-diabetes as well as diabetes. So this is now the IDF 2009 harmonized criteria for the metabolic syndrome. And in the Philippines, the prevalence of the metabolic syndrome, again in the 2013 FNRI National Nutrition Survey, is around 33%. So 1/3 of all adults have the metabolic syndrome. And the elevated blood pressure, as defined by diastolic BP of more than or equal to 130, or diastolic BP of more than or equal to 85, is around 36%, encompassing pre-hypertension as well as hypertension. Now let's go to the next bullet point and talk about the pathophysiology of hypertension in diabetes and metabolic syndrome. And recognize that even if over many years that type 2 diabetes has been recognized to have many pathophysiologic mechanisms, such as what we see here in this figure, the ominous octet, the basic or the core pathophysiology of type 2 diabetes is still insulin resistance, as well as decreased insulin secretion or beta cell failure. The core defects in type 2 diabetes, aside from insulin deficiency and insulin resistance, there's actually a third one, the increased hepatic gluconeogenesis leading to hyperglycemia. Again, as I said, please remember though that before we develop beta cell failure, before there's a decrease in insulin secretion, there's actually hyperinsulinemia. And this hyperinsulinemia is brought about by the fact that our beta cells, in response to insulin resistance, produce more insulin to compensate for the increased insulin resistance. So that initially, let's say at the point where we have pre-diabetes, or even before that, because of our genetic predisposition, certain environmental factors such as decreased physical activity or increase in caloric intake, we develop insulin resistance, sedentary lifestyle, increased food intake. However, our body is able to cope because our beta cells make more insulin. So our sugar doesn't go up initially. If we let this go on over many years, we do not alter our lifestyle, then subsequently the beta cells start to die off. Then we develop insulin deficiency, and therefore this becomes full-blown type 2 diabetes. But before all that, we have insulin resistance and hyperinsulinemia. So before I talk about how insulin resistance and hyperglycemia are related to the development of hypertension, let's take a look at normal physiology and remember that arterial pressure is what determines our arterial pressure is our cardiac output and the peripheral resistance. And cardiac output is the product of stroke volume as well as our heart rate. On the other hand, peripheral resistance is a product of the vascular structure, how thick our vasculature is, and the vascular function, how vasoconstricted our blood vessels are. Both the cardiac output and the total peripheral resistance, though, are influenced by multiple genetic and environmental factors. And typically, it's that same genetic and environmental factors that also brings about the insulin resistance and subsequently the hyperglycemia. Moving on, we recognize that blood pressure is the product of cardiac output and total peripheral resistance. Cardiac output is again, the product of our heart rate and the stroke volume. No? So the blood volume is how much blood we have is determined by sodium, how much sodium we retain, certain hormones like the mineralocorticoids and atrial natriuretic peptide, and the cardiac factors are the heart rate and the contractility. On the other hand, our peripheral resistance is again brought about by humoral factors. We have several vasoconstrictors, foremost of which is angiotensin 2 and the catecholamines, and certain vasodilators. Likewise, there are neural factors, the alpha adrenergics, which are constrictors, and the beta adrenergics, no, which are the dilators, and various local factors such as autoregulation and hypoxia. So please keep this in mind as we move on and talk about how hyperglycemia and insulin resistance affects our blood pressure. So insulin resistance, like I said, induces hyperinsulinemia. And so even very early on, no, before we develop full-blown diabetes, there's an increase in sodium reabsorption from the renal tubules and consequently an increase in the blood pressure. Once we have full-blown diabetes or even in pre-diabetes, the hyperglycemia leads to systemic blood pressure elevation by increasing the circulatory fluid volume. You remember that glucose, no, attracts water because of its high plasma osmolality. The high plasma oncotic pressure attracts water, increasing our increasing the volume, no? And as water exits into the tissue, into the vasculature, this reduces the difference between the intracellular and extracellular osmotic pressure, increasing the extracellular fluid volume, and that is the circulatory blood volume. The hyperinsulinemia in insulin resistance also stimulates the sympathetic nervous system. So remember the humoral as well as the neural factors. This is the humoral factor, increased renin, and an increase in the sympathetic tone. Renin activates the sympathetic nervous system and increases the cardiac output and the peripheral vascular resistance, which ultimately leads to BP elevation by increasing both the circulatory fluid volume and the peripheral vascular resistance. Moreover, insulin stimulates obesity through fat accumulation, and this leads to obesity-induced hypertension in association with type 2 diabetes. And then much further on, no, as the hyperglycemia is uncontrolled, this can lead to complications in the kidney, and the development of diabetic nephropathy further leads to uncontrolled blood pressure. So we can see that in diabetes, it is the drivers, no, or in metabolic syndrome as well as diabetes, the main driver of the increased blood pressure is not only the elevation of the blood sugar, but as well the insulin resistance. The increase in the blood sugar attracts water, but on the other hand, the insulin resistance leads to an increase in many humoral factors, as well as the increase in the sympathetic tone, which then leads to increase in the peripheral resistance. Recognizing that in type 2 diabetes, the increase in the renin, which eventually leads to the conversion of angiotensinogen to angiotensin 1 and then angiotensin 2, no, these are drivers of the increased blood pressure. This is also the reason why the RAS blockers, the ACE inhibitors, and the ARBs are actually best, no, among persons with diabetes as well as insulin resistance. The hyperglycemia as well as the hyperinsulinemia also directly induce medial and intimal thickening. So not only functional vasoconstriction, but actual anatomical changes, no, medial and intimal thickening in the afferent arterioles, which causes dysfunction in contraction and dilatation, leading to failure of optimal control of the glomerular pressure. And so this is how the development of diabetic adaptations in the kidney and the diabetic nephropathy also contributes to hypertension. And like I said, no, many of the risk factors for hypertension, such as unhealthy diet, physical inactivity, being overweight and obese, no, the genetic factors, no, as well as the social determinants for hypertension are the same ones that are present, no, among persons with diabetes. So how about the link between obesity and hypertension? We know that as the BMI increases, no, the risk, no, for CV mortality also increases. Whether you have hypertension in blue, but more so, no, if you have already hypertension. So there really is an interaction between obesity and hypertension in the way that they increase the cardiovascular risk or the risk for CVD mortality. And here you can see that in the highest BMI, more than or equal to 35, you can see that the risk for CV mortality is more than double, no, among this group of individuals. So this is taken from the Chicago Heart Association Detection Project in industry cohort, no, where they stratified them by baseline body mass index and the hypertension status and followed them up over more than 30 years and found out that those who have higher BMI, so here more than 25, whether they have hypertension or don't, no, are of higher CV risk, but more so, no, among those with both obesity as well as hypertension. Really, the risk, no, for CV mortality is much, much increased. And the pathophysiology of hypertension and obesity is again similar. The presence of the central or abdominal obesity is really as an outcome of insulin resistance, no? The increase in the leptin is associated with increase in the blood pressure. And much like in diabetes, no, or in hyperglycemia, the increase in the sympathetic tone, the increase in the renin, angiotensin, aldosterone activity, it's the same driver, no, in obesity. Even if it's isolated obesity, they're not yet diabetic. Likewise, the salt sensitivity among persons who are obese, no? I talked about the increase in the renal sodium reabsorption that's brought about by the increased sympathetic tone, the hyperinsulinemia, the increase in the renin, angiotensin, and then also the aldosterone. All these are drivers of the increase in the blood pressure among persons with obesity. And some other potential mechanisms for hypertension in obesity as well as metabolic syndrome is the decrease in the atrial natriuretic peptide, no, which is a diuretic, a decrease in adiponectin, the presence of obstructive sleep apnea, which activates the sympathetic nervous system and enhances or increases the aldosterone levels. Those who have low birth weight, no, are actually more prone, no, to develop obesity or excessive weight gain in childhood and adolescence, with again increased risk of hypertension. And the endothelial dysfunction that is found in various spectrum of insulin resistance leads to a blunting of the physiologic dilatation. So how do we treat hypertension among persons with obesity, metabolic syndrome, and diabetes? Of course, we talk about non-pharmacologic therapy first, no? And the general advice, no, among these persons is actually the same, no, as in the general population. And this is taken from the Philippine Practice Guideline for Hypertension in 2020. So sodium restriction to as low as 1,500 milligrams per day, the DASH meal plan, aerobic physical activity and dynamic resistance exercises, abstinence or moderation of alcohol intake, and weight loss of more than or equal to 5% of the baseline weight, and of course, smoking cessation. The non-pharmacologic therapy for persons with diabetes and metabolic syndrome, as well as hypertension, it's the same advice no, as in the general population with hypertension. So sodium restriction to as low as 1,000 milligrams per day. The American Heart Association recommends sodium intake to be limited to 2,300 milligrams per day, which is roughly half a teaspoon of table salt in most healthy individuals, and 1,500 milligrams per day in people with prehypertension or hypertension. So imagine less than a teaspoon of table salt. We also recommend the DASH diet and aerobic physical activity. And the DASH diet is a diet that's rich in potassium, in fruits, vegetables, low-fat dairy, fish, whole grains, fiber, potassium, and other minerals at the recommended levels, and low in red and processed meat, sugar-sweetened foods and beverages, low in saturated fat, cholesterol, and sodium. We also encourage, of course, smoking cessation, abstinence or moderation of alcohol intake, and weight loss of more than or equal to 5% of the baseline weight. Among persons with diabetes or obesity and hypertension, we also encourage screening for obstructive sleep apnea, excessive daytime sleepiness, loud snoring, and witness apneas. No? As OSA has been found in RCTs, no? If you treat it using CPAP, then it can potentially reduce the blood pressure. Just to show you the effects of treating of the non-pharmacologic therapy, adapting or having a weight reduction can lead to 5 to 20 millimeter mercury for every 10 kilogram weight loss. Adapting the DASH diet leads to a BP drop of 8 to 14, and restriction of salt in the diet around 2 to 8 millimeter mercury. Physical activity around 4 to 9 millimeter mercury, engaging in aerobic physical activity such as brisk walking, Zumba, for example, of at least 30 minutes per day on most days, and moderate alcohol consumption around 2 to 4 millimeter mercury. So not a lot, no, but if you put together all these, no, and initiate all these, they can significantly drop the blood pressure, and among the pre-hypertensives can control the blood pressure. Other non-pharmacologic approaches is to reduce the exposure to air pollution and cold temperature, as evidence from studies support a negative effect of air pollution on blood pressure in the long term. So of course, this is a public health concern in areas of the country, in our cities with very high air pollution, no, that is directly linked to the development of hypertension. Now, going to the pharmacologic therapy, we can see that among persons with diabetes, what is the threshold for treatment of elevated blood pressure? It is recommended to initiate drug therapy along with lifestyle change at a blood pressure threshold of more than or equal to 140 over 90 millimeter mercury to reach, no, and the non-pharmacologic therapy is the same, no, as the general population. So we treat at the threshold of more than or equal to 140 over 90. And we aim, no, for a BP target of less than 130 over millimeter mercury. However, we do not want it to be less than 120 over 70, on the other hand, due to an increased risk for adverse events. Now, why are we so aggressive, no, in controlling hypertension? Again, 140 over 90, we start treatment to reach a BP goal of less than 130 over 80. BP control among persons with diabetes is often difficult, requiring typically 2 or more medications to achieve the target. But treatment of hypertension actually confers greater benefits in people with diabetes than in age-matched people with hypertension who do not have diabetes. The benefits of intensive BP lowering may even exceed those of intensive glycemic control for the prevention of cardiovascular complications. And we recognize that people with diabetes don't die of diabetes per se. It is cardiovascular disease that is the most common cause of death among persons with diabetes. And thus, blood pressure control is really paramount. If we take a look at the UK PDS trial, where they did both tight BP control as well as tight blood sugar control, we found out that it is actually the better blood pressure control. Only around 4 millimeter mercury drop in blood pressure already prevents to 12.5 CV events. And this is for LDL cholesterol lowering. Just a 1 millimole drop in LDL drop leads to the prevention of around 8 CV events. And if you take a look at lowering the A1C by around 1%, an NNT of around 87. So compare 87 for blood sugar lowering, 8 for cholesterol lowering, and 12 and a half CV events for blood pressure reduction of only 4 millimeter mercury. So the benefits of glycemic control is really modest in terms of the CV outcomes. It's really more for the microvascular complications. But if you control lipids and the blood pressure, that can have a major impact on CV outcomes. So among persons with diabetes, what are the preferred drugs for the treatment of hypertension? It's recommended to initiate treatment with low-dose combination of a RAS blocker, that's an ACE inhibitor or ARB, with a CCB or thiazide-like diuretic, using a single pill combination. And the evidence for this comes from a network meta-analysis of 27 studies with around 50,000 people. And there was no benefit of any single antihypertensive class in the reduction of mortality among hypertensive persons with type 2 diabetes. The reduction in CV mortality was only found in the ACE inhibitor and CCB combination. And in other studies, the combination of ARB and another drug class, which was not part of this network meta-analysis, is the basis for why we also recommend those combinations. So ACE or ARB plus CCB, or ACE plus or ARB plus thiazide or thiazide-like diuretics. So again, just to round up this discussion, for the greater majority of persons with diabetes and hypertension, we need combinations of medicine to achieve BP control, since most patients end up with 2 or more combinations of drugs anyway. And we need to be adept at combining medications because, like I said, it is difficult to control the blood pressure of persons with already established diabetes. But if you are able to do that, BP control has a much greater impact on cardiovascular outcomes than even glycemic control. So please remember that among persons with type 2 diabetes, the BP threshold for drug treatment in hypertension is 140/90 to reach a target of less than 130/80 millimeter mercury, but not lower than 120/70. Now, how about the BP targets in obesity and hypertension? Currently, there are no specific treatment goals for obese hypertensive patients. And so the goal is probably similar to those that we recommend for other high-risk groups, including patients with diabetes. That's less than 130/80. Based on the JNC8 target, it's still less than 140/90, but we generally, like I said, adapt the threshold of, we adapt the BP target of less than 130/80. There are actually no long-term controlled studies that have specifically addressed the issue of efficacy and safety of the different drug classes, antihypertensive drug classes in obese patients. So I'm talking about those with just obesity. They don't have metabolic syndrome yet or diabetes. But there are certain precautions. No, we are advised to try to avoid or use with caution thiazide diuretics. This is true also for persons with diabetes, as it may predispose and worsen glucose tolerance, leading to overt diabetes. So if you will use the thiazide diuretics, let us use the low dose, no, in combination, 12.5 to 25, because we know that the ACE, no, as well as the ARBs, on the other hand, improve insulin sensitivity. In the all-hat trial, there's actually a higher incidence of diabetes when chlorthalidone, no, a thiazide diuretic, no, was used compared with lisinopril among patients with the metabolic syndrome. However, there was no difference in new onset diabetes between chlorthalidone and amlodipine among those who did not have metabolic syndrome. Now, the precaution with using beta blockers, no, the mechanism is still unclear, but it could potentially make weight reduction more difficult. And it might be related to the reduction in the sympathetic tone, as beta blockers diminish the basal metabolic rate. Potentially also, when you use beta blockers, there may be an inhibitory effect of the catecholamines on the appetite. So in this lecture, I talked about the management of hypertension among persons with diabetes, obesity, and the metabolic syndrome. I said that metabolic syndrome, as well as isolated diabetes and obesity, are associated with hypertension. Both the increased plasma volume and the increased peripheral vascular resistance are seen in diabetes as well as obesity. And weight loss and non-pharmacologic approaches are the cornerstones of management. There are no specific drugs for obesity and for hypertension in obesity, but combinations of RAS blockers with CCBs or RAS blockers with low-dose diuretics are recommended for persons with diabetes and hypertension. And the target blood pressure for diabetes, obesity, and the metabolic syndrome, the target is less than 130/80 millimeter mercury. So that's it. Thank you very much for listening. Thank you very much for your time and attention.